All right. All right. Good morning. Good morning. Thank you so much for coming to this month's Equity Matters. It is our year in review. And we are so honored to have our Deputy Secretary, Chief Health Equity Officer with the North Carolina Department of Health and Human Services, Ms. Deborah Farrington. Thank you so much for joining us today, Ms. Deborah. Um, Today, we will be having a discussion, and our subject is Reflect, Renew, and Rise Building Bridges to an Equitable Future. So, we'll be talking about what has happened in the past in terms of challenges and progress in terms of health equity for the state of North Carolina. What are we doing right now in terms of health equity for the state of North Carolina, and a forward looking approach of what is coming down the pike and how we can continue to advance health equity and ensure that our community, all of North Carolinians, are safe, healthy, and wise. So we are so pleased to have her today. Thank you so much for joining us, Ms. Deborah. How are you doing today?
I'm doing well. How are you?
I'm doing amazing. I'm so glad to be here as this year in review. I've had 12, this is going on my second year of doing Equity Matters. So I'm so happy to be able to continue this series. I think it's a benefit to our community. Do you want to share about who you are and how you came into the space of Deputy Secretary and Chief Health Equity Officer for the state of North Carolina?
I'd be happy to share. Um, I came into this role after having worked in North Carolina Medicaid for a
Hmm.
couple of years as the chief of staff. And that part of my journey is important because um, I moved into that role a little while, late 2019,
Hmm.
and started out helping Medicaid as we transitioned into Medicaid managed care.
Hmm.
You all know that in 2020, we had the death of George Floyd and
Yes.
also entered into a pandemic. And it was a time when we were, as a nation, I think, really compelled to look at the experiences of all US citizens to figure out where everyone experiencing their best opportunity for a healthy life, a prosperous life. And so after the death of George Floyd, we actually asked our staff to share with us because it was such a profound, I think, event. We asked
Hmm.
them to share their feelings with us. We brought people together to hear their concerns and just to acknowledge that it was a time of a lot of turmoil for our country and personal pain for some individuals. What we discovered was that, yes, people were having strong reactions to that, but also we discovered that people had feelings about their workplace,
Hmm.
and what it was like for them as individuals to be employed with Medicaid and what their experiences were. And we found out that not everyone had the same experience, that some folks had experienced what they defined as injustice in the workplace.
Hmm.
And so as we dug into that, we determined that we needed to chart a path forward for how do we hear from our staff about areas of concern, how do we examine our policies, our decision making, and our engagement of staff in a way that lived out our values because we were a value-based organization that was really concerned about Medicaid recipients and the people who needed our services most. But we knew in order to do that, that we had to support a workforce that felt that they were working in a just and fair environment.
Hmm.
And so I give a lot of credit to the then Medicaid director, Dave Richard, who really led us through a process of doing the internal work necessary to make sure that we had a just and fair environment for people to work in. And that really launched my work at the North Carolina Medicaid office for digging into issues of justice and fairness, which later um, led to some of the work I'm doing as Chief Health Equity Officer. While I was at Medicaid, we also started to look at some of our equitable approaches for addressing the services we delivered. And I think that served as the foundation for what I'm doing now. which is, as Chief Health Equity Officer, my role is to support the department to make sure that everyone has their fair opportunity for health.
Mhm.
We deliver whole person care, and we want to make sure that people are well and supported, that we champion the best health outcome for the 10 million plus North Carolinians that live in this state. And so my job is to help us do that by identifying those populations who are experiencing worse health outcomes and
Mhm.
figuring out what do we do from a policy and programmatic approach to narrow the gaps that we see in health outcomes for some populations.
Yeah, thank you for giving that comprehensive understanding of how you started and also including the importance of justice and fairness. So I'm hearing you, and what I hear is that North Carolina takes a health justice approach to when they're looking at population health to ensure that our community is able to have the things that they need in order for them to have the most optimal health that they determine is best for them. And with that health justice approach, that is looking at one of the most recent findings that you all have, reports that you all have released, is the North Carolina Health Disparities Analysis Report. And that was released, I guess, about 4 or 5 months ago, if I'm correct. Do you care to share about the North Carolina Disparities Report that was released?
Yes, I'm happy to provide some more details about the report that was released in September of this year. The report is the next in a line of previous reports. I think the last one we released was in 2018.
Mhm.
This health disparities report, though, was different because it was designed to highlight the most significant health disparities that we are recognized at the Department of Health and Human Services. And we were really focusing on those health disparities where we feel like we had the greatest opportunity to make an impact over the next 3 to 5 years.
Mhm.
When we started compiling the data or evaluating the data for the health disparities report, you can imagine that there were a vast array of disparities that we were able to
Mhm.
identify. But we did want to target in on what are those disparities where we can take meaningful actions to address the disparities.
Mhm.
The report also provides measures
Mhm.
and a starting point for us to track our progress in eliminating health gaps and experiences by populations that have been marginalized. In the report, we describe services and programs and resources that are dedicated to identifying addressing the identified disparities. And finally, we emphasize, and you asked me about this in preparing for this to figure out what can communities do. This
Mhm.
report actually identifies actionable strategies that a lot of folks, any number of people can take to help us address disparities and seek solutions.
Mhm.
And so it's actually sort of an intentional call to action
Mhm.
for our whole community. Um, a few other things I want to highlight about the report, and I'm just going to reference my notes. So if you see me looking off to the side, I
Oh,
want to
no
be sure I
problem. I
cover
got my
all the
notes
relevant.
too.
Yeah, I want to give as much information as I can, as many details as possible.
Mhm.
Um, so one of the things I mentioned that the report takes a different approach. In our previous reports, we would list the disparities by race and ethnic
Mhm.
categories.
Mhm.
But this report looks at a broader list of population groups across, yes, dimensions of race and ethnicity, but we also look at people with disabilities. We look at
Mhm.
veterans. We look at disparities experienced by rural communities. And so we wanted to take a broader look across a variety of population groups. We also identify success stories in the report where we spotlight people or programs that have been impactful in helping to move the needle with health disparities. We talk about Medicaid expansion, which is a huge changer for North Carolina. We talk about our behavioral health investments as a success and the medical debt relief program. Throughout the report, we talk about our collaboration with partners And then we organize the data and information in 6 different focus groups: social determinants or social drivers of health, access to health, chronic disease, communicable disease, mental health, substance use, suicide, and violence prevention is all grouped into one group. And then the final category is health disparities or health across the lifespan. So we focus in that broad category on the health of children, the health of older adults. Um, and at some point, I would love to share with you some of our key findings
Yeah,
for
sure.
disparities. You want me to delve into that now?
Sure, go ahead.
Okay, great. So we look in the social drivers of health category. We looked at the limited access of people to those social determinants, that we have a lot of areas in our state where people are food insecure. We have too many areas in our state where um, people don't have a grocery store or have to drive long distances to
Hmm.
get to a grocery store. That we talk about that in the health disparities report. We identified disparities for um, historically marginalized population by race, ethnicity, location, income levels, disability status. And we also talk about the fact that there are higher poverty and unemployment in certain ethnic communities and racial communities. So there are a lot of things that we're digging in on the social drivers level. Um, in chronic disease, as an example, we identified that there are higher rates of chronic disease and death in Black, American Indians, and Latino communities. We
Hmm.
also saw higher chronic disease in people with disabilities, uh,
Hmm. Hmm.
higher rates of cancer, higher rates of high blood pressure and diabetes and heart disease. And so we talk about some of those key findings there. Um, and then finally, I'll say in the communicable disease area, we note that there are higher rates of syphilis and higher rates of HIV
Yeah.
in African American communities and American Indian communities and
Hmm.
in the Latinx communities. And then we talk about higher rates of communicable diseases in the LGBTQ communities as well.
Hmm.
So that's a few examples of some of the disparities that we saw and identified in the health disparities report.
So when we are talking about one of the highlights that I heard you mention was about Medicaid expansion, and a part of HB 76, which is actually the Medicaid expansion bill for those who don't know. Um, a part of that also was talking about capacity and structure when it comes to hospitals and providers. With Medicaid expansion, one of the wonderful things is that we have so many North Carolinians that are now insured. And that's a wonderful thing, a wonderful opportunity for people to live their best health. But on the other side of that is how do we gain or provide access to providers? Because we're also looking at in rural communities that there's a shortage of providers in some of our rural communities, whether it's federally qualified health centers, which would be such a benefit if we had more in those areas, or just providers in general. So, how is North Carolina looking at trying to address that space with our rural communities? We have large pockets of communities, right, such as Raleigh, Durham, Charlotte, Greensboro. Wilmington is a larger space in the southeastern North Carolina, Charlotte. But in between all those areas, there are many different smaller communities that are actually don't always have access, especially with so many community hospitals now being bought, and some are being closed and being bought by larger hospitals. So, what are we doing in terms of Healthy North Carolina or just North Carolina in general to try to address that inequity?
Yeah, we're doing a lot. We actually have the Office of Rural Health that's
Hmm.
specifically focused on building our capacity to
Hmm.
primary care in our state. Their focus, however, is on the rural areas of our state that have more difficulty attracting and retaining providers.
Hmm.
Part of the goal of that office is also to support the safety net that you mentioned. Our federally qualified health centers, our FQHC lookalikes. We support rural and free clinics, and we support hospitals, especially those critical access hospitals that exist in our rural communities.
Mhm.
And some of the ways that we do that is through our community health grants. We provide funding to community agencies,
Mhm.
to primary care access providers to make sure that they can sustain the service delivery system. Often they bill Medicaid. Obviously, that's going to be their primary source of funding. They may bill Medicare, but they may need to have additional funds to support their infrastructure that they can't use their Medicaid funds to support. And that's where
Understand.
our community health grants come into place. We
Mhm.
actually just recently released an RFP to invite more providers to respond to our community health grant.
Oh, that's
Um,
good.
and through that process, we have awarded a number of awardees already. Additionally,
Mhm.
the other thing we're doing to provide additional support is with our telehealth infrastructure.
Mhm.
Because getting to physical locations is sometimes a challenge for members of our
Mhm.
community, we deliver telehealth, and we support that. And so we recently released a telehealth RFA. Um, and in our first wave of awardees, we awarded 34 applicants with over $7.3 million to be able to deliver and to build up their capacity to deliver telehealth. We're going to release another wave of those telehealth grants um, soon, and expect that at the end of January, I think, and expect that impacted communities, for instance, those out west, will be able to respond to that RFA, and
Mhm.
hopefully we'll be able to get additional dollars out into the community. There are other ways that we're supporting access to care in rural areas, and one of the ways we do that is with our loan repayment program, because we want to attract and retain providers in rural communities.
Mhm.
And with our loan repayment programs, providers can apply to have loan forgiveness.
Mhm.
Um, and we have many, many providers who are participating in that program and use that as a way to build up our safety net. And I mentioned we support uh, the critical access hospitals.
Mhm.
Um,
Mhm.
we help to identify hospitals that may be struggling. We provide technical support. We help them get access to additional federal dollars um, that will enable them to maintain their infrastructure and hopefully keep hospitals open. The other thing we're doing, and I'll say this and then I'll let you go.
Mhm.
One of the other things we're doing to support rural access is by building up some of our maternity care programs, where
Mm.
we are increasing access to doulas and
Mhm.
others who can serve individuals, where we see fewer obstetrics and gynecology programs in rural areas. We're doing things to support that discipline and that
Mhm.
profession so that people can get access to a variety of maternity care.
And that's really needed, especially like I said, in our rural areas, that doula care can really be the change. And it can actually be the life or death change, but for some women in those spaces, because they don't have access to a regular provider. We do know that doulas are not like medical providers, but they are there to be able to assist and help women as they're going through certain maternal issues, and then help them get in contact with access to care. So it's a wonderful service that is needed, and we actually need more doulas. And so I love that opportunity that you all are bringing there with the telehealth. That really plays in line with North Carolina's approach to. We have given, I think, almost $30 million to digital equity, so that really is helping us get into that space to make sure that not only with the telehealth structure, that you have the infrastructure that is there to allow people the opportunity to be able to participate within the telehealth side. So that's really important. And so I thank you for highlighting that. Would you like to discuss your when it comes to that Healthy North Carolina 2030? To my understanding, it's a population health framework, and it has a health equity lens to drive the plan. Um, what are some of the findings that you all have from the Healthy North Carolina 2030 and where we're going in that direction?
Yeah, I appreciate the opportunity to talk about the Healthy North Carolina in 2030, which was developed in partnership with the North Carolina Institute of Medicine.
Mm-hmm.
And what that report does, is it projects targets for North Carolina to improve health of North Carolinians. And it does that by facilitating this state health improvement plan, which is what it is. The plan identifies areas of needs, and it also helps us to direct resources
Mm-hmm.
to positively impact those drivers of health that we see in our state. Um, the Healthy North Carolina 2030 focuses on a population health approach, and it specifically talks about health equity, social determinants of health, and talks about how we can engage community members, policymakers, people who are in the public health sphere, social service agencies, um, to address the needs of our community: transportation, education, public safety, housing. Um, and we ask those community partners to join with us to identify these selected health indicators where we set targets for how we want to move
Mm-hmm.
and make progress in the next 5 to 10 years.
Mm-hmm.
As a part of the process, we used a results-based accountability structure, which is a process-driven, plain language approach in moving us from just talking about health inequities and health disparities to really taking action to
Mm-hmm.
address those health disparities. Healthy North Carolina 2030 identifies 21 population-specific health indicators, what they called wicked problems.
The problems, yeah.
Yes. And these became the
Do we want to
basis.
define for our community real quick what a wicked problem is? I can if you want me to.
Sure, feel free,
Okay.
and I'll elaborate.
Okay, so a wicked problem for those who may not understand is that once you open or once you solve a problem, it has inopportune consequences where it opens up other issues. So, in so many ways. So that's one definition of a wicked problem. So, if I go in and let's say I fix a plumbing issue, but by fixing the plumbing issue, it thereby then causes other issues. Let's say the sink is not working correctly, or let's say the plumbing issue then causes another issue in terms of the structural framework. So you fixed one issue, but then it causes another particular issue. So that's what we refer to when we call a wicked problem.
Yes, and I love that description because one of the things we know about the wicked problems in North Carolina's plan
Mm-hmm.
is that they are persistent problems, and that they
Okay.
are, to your point, they are intricately linked. And
Mm-hmm.
so when we look at issues of um, justice involved communities where we see higher rates of people of color in the
Yeah.
justice system, or if we look at other kinds of drivers, the number of children who are in foster care, as an
Right.
example, those things are a part of a larger system, to your point,
Yes. Mm-hmm.
that requires us to address multiple things at the same time.
That's
And
right.
so
Mm-hmm.
for us, we wanted to look at those wicked problems that were persistent,
Mm-hmm.
that were interconnected, and that would give us an opportunity to make um, significant improvements in the health outcomes.
Mm-hmm.
Um,
Mm-hmm.
as an example, one of the health indicators looks at the incarcerated population that I mentioned before, and we talk about who are the people that are impacted, and then what is the desired result.
Mm-hmm.
Um, and in this case, the desired result obviously is to dismantle where we see racism. We
Mm-hmm.
see health disparities example for those populations, where we see African American populations represent about 22% of
Mm-hmm.
North Carolina's population, but represent about 50% of the prison population. And so North
Mm-hmm.
Carolina, as a Department of Health and Human Services, is specifically looking at how we can address the needs of justice involved populations. It's in
Mm-hmm.
our Healthy North Carolina 2030 plan. It will be a part of our 1115 waiver that the
Mm-hmm.
state has recently got approved for. Again, we see historically marginalized populations overrepresented in
Mm-hmm.
prisons and in jails, and underrepresented in behavioral health settings where they need to get services. And so through our Justice Involved initiatives, we will begin to figure out how we can close the gap in the
Mm-hmm.
proportion of people who are represented in that population. And we are already seeing extremely positive results with some of our Justice Involved initiatives. And based on the last 12 months of data that we had reported on from our behavioral health team, our diversion and reentry programs have seen an increase in the proportion of populations who have been marginalized to
Mm-hmm.
60% of those who are in our Justice Involved initiatives that the
Mm-hmm.
department is leading. 60% of those are people of color. So we
Mm-hmm.
are putting the services where the area of need is.
That's really important. I think a lot of people, when we are having these conversations about health equity, they always just think about just the general population. They don't think about, or it's behind I guess, behind the curtain, so to speak, that conversation when we should be including our justice involved population. It really impacts. It's part of the ecosystem of health equity that people don't realize, because if you have a justice involved mother, um, the ramifications from that is just there's no way to account for all that. Is if that mother is pregnant when she goes in, then she has to deliver. Who's going to take care of that child, once that child is back into general population? Who's going to provide for that child? Then the mental health of that actual mother, from actually having to release her child into, normally she's going to be with me and take care of me. So that is such a great initiative that you all have, because I think people do not understand like how that really, really, really goes deep into our people of color, our Black communities, and our Hispanic communities and Indigenous communities that are overly represented within our incarcerated spaces. It comes back into our communities in such unseen ways that people don't realize. It's like I like to say, like the secrets in plain sight type of thing. It's right there in front of you, but you don't realize what is that thing that's causing an issue
Mhm.
for communities, and it's deeply rooted. So I love the fact that you all are focusing on that space. When we talk about some of the achievements for North Carolina, that in itself is one of the achievements that, as you've highlighted. Do you want to highlight some other achievements that North Carolina has had in terms of advancing health equity?
Yes, I'd love to. We've done a lot at the Department of Health and Human Services. I'll talk about some of the things that we've done at the department, and I'll also
Mm-hmm.
talk about some things we've done as a state, things
Mm-hmm.
that you and members of your audience have likely been engaged in. One of the things we did as a department and had a lot of input from partners in our behavioral health system is that we updated our Olmstead plan. You
Mm-hmm.
all know that the Olmstead um, initiative results from a U.S. Supreme Court decision that looked at um, people who had been not had their fair opportunity to live their best life in the community. People with disabilities who had been
Mm-hmm.
institutionalized, and so that U.S. Supreme Court decision required states to intentionally address the needs of people with disabilities in the community. And so we updated our plan, which focused on how, our goals and how can we make sure that people have employment in the community, that they have housing options available to them in community settings, and then how do they have the services and supports they need
Mm-hmm.
to live a life in the community that's enviable. And so that Olmstead plan lays out North Carolina's path that we're well on the way to meeting the needs of our people who have disabilities. We also released and updated our transition to community living
Mm-hmm.
implementation plan. And that initiative was based on a settlement agreement with the U.S. Department of Justice that focused specifically on adults with severe and persistent mental illness who were living at the time in institutional settings or in adult care homes, which for
Oh.
many was not an appropriate setting for them.
Mhm,
And so our transition to community living program is focused on how do we create opportunities and real life experiences for people with severe and persistent mental illness to live in homes of their choosing,
mhm,
work at jobs of their choosing in community, and get the supports that they need to stay in community.
mhm.
And so we have been working on that. There's going to be lots of good news to come about that because we are really seeing North Carolina make significant progress in that area. You talked about our health disparities report that we released. That was a big accomplishment for us this year. We're also doing some things internally to support the North Carolina team. Um, but one of the two things I want to talk about, which is pretty significant for our entire state, and one of them is Medicaid expansion.
Mhm.
So you all know that the greatest health disparity is lack of access to care, lack of access
Absolutely.
to health care.
Mhm,
And with the expansion of Medicaid, North Carolina is in a position to make sure that people no longer have to choose between um, buying food or
right.
buying medicine. And in talking about people in rural communities, we know that people in rural communities have significant access to health issues, as
Mhm,
you mentioned, Fawn. And what we're seeing with Medicaid expansion is that um, people in rural communities who are typically underserved are
mhm,
actually those who are benefiting the greatest from
mhm.
Medicaid expansion. We've
Good.
seen nearly 40% of the expansion population come
Mhm.
from rural communities. And
Okay.
typically, our community population is only about 20% is from
Mhm,
rural communities. So that's a significant advancement for us that we're reaching so many people from rural communities. We also know people of color disproportionately lack access to care,
mhm,
and we are seeing improvements in that area as well. So last year, December 1, North Carolina became one of the few remaining states
mhm,
to expand access to Medicaid under the Affordable Care Act. And with that, we celebrated our 1 year anniversary of Medicaid
mhm.
expansion, December of this year. And we have over 601,000 people in North Carolina who are
Wow.
now able to get access to care because of Medicaid expansion.
That's
And that's the
wonderful.
result of all of the work that your audience members and people in the state have done with advocacy and outreach. And we're seeing the fruits of their labor come to bear with over 600,000 people being able to get access to care. And I'll just say, we thought it would take us 2 years to reach 600,000 people. So the
Mhm.
fact that we have more than 601,000 individuals a part of the expansion population speaks to the level of need, but it also speaks to the level of effort and engagement and commitment with our being able to make this much needed resource available to people.
And I will probably say my social services director, Tanya Jackson, would say she's given you approximately 20,000 people.
Excellent. Very good.
That she has worked hard within New Hanover County to get people enrolled in Medicaid expansion. So shout out to Tanya Jackson for doing a great job from the social services side to get people involved. Those are wonderful highlights and achievements that we are looking at for the state of North Carolina. And so with that understanding, what are we doing now? What are some things that are ever present that we still need to improve and work hard on, some barriers that we are seeing that you need our local communities to uplift more and be a lot more a part of. Um, when I think about what's happening in our community, a lot of times, many things when we talk about health equities are actually systemic and structural, that are actually embedded into the policy framework of how people are doing things. So, although we might have wonderful things that our community are from our state that are being passed down, how do we get our community to actually latch on to those things to help remove those systemic and structural barriers that are in place?
Excellent, excellent question. And I'm going to talk about it from two different angles. One, what we're doing to address a major barrier, and then how the community can get involved.
Mm-hmm.
Um, Poverty and access or lack of access to economic resources is
Mm-hmm.
a significant driver of poor health outcomes.
That's right.
And one of the ways that people sometimes sort of languish in poverty or not have opportunities for economic advancement is because of debt. And
Mm-hmm.
in North Carolina, we started to make some significant progress towards eliminating medical debt. And
Mm-hmm.
Medicaid expansion actually um, was a path through which we were able to address medical debt, because with it, it gives us an ability to, um, with Medicaid expansion, gives us an ability so that people don't have to build up thousands of dollars in medical debt that they can't afford to pay. It's a burden that impacts every North Carolinian, regardless of race, where you live, how much money you make in some cases. Medical debt is a huge issue, and hospitals in many cases have to carry this debt, but have limited ability to actually recover. They only recover a small fraction of the
Yeah.
debt that they are owed. And
Mm-hmm.
so in July of this year, our Governor Roy Cooper, along with our North Carolina Department of Health and Human Services Secretary Cody Kinsley,
Mm-hmm.
announced that we would be employing new action to be able to leverage our Medicaid expansion program to encourage hospitals to relieve existing medical debt from millions of people who were low to middle income.
Mm-hmm.
Um, and by easing this medical debt, now we also ask them to look at how they would have opportunities to ease medical debt in the future.
Mm-hmm.
Because when people got access to care through Medicaid expansion, they were elated, obviously, that they could now get their medical needs addressed. But some people had stacked up thousands of dollars and across the state, millions of dollars in debt. And so we had all 99 of our acute care hospitals in North Carolina agreed to participate in this program. And
Mm-hmm.
what it does is it actually relieves outstanding medical debt dating back to January of 2014.
That's a
And so
long
when you
time.
talk about a barrier for people, sometimes people would not go to the hospital, and you know this, Fawn. Sometimes people would not go to the doctor or go to the hospital because they didn't want to accrue or incur more debt.
That's
And
right.
so this is a huge, it's a barrier to treatment, but it's also a huge path that now we have a remedy that
Mm-hmm.
people can have some of their medical debt relieved, and then they won't have to incur future medical debt. And it's primarily targeted to people who are in Medicaid. They can have their medical debt relieved back to 2014. But if people are not a part of Medicaid, but they have incomes at or below 350% of the poverty level, federal poverty level, um, and those people who owe a certain amount of medical debt, participating hospitals have to limit the amount of debt that people can be charged.
Mm-hmm.
Um, it also relieves medical debt that's more than 2 years old, going back to 2014. And hospitals have to agree to set up some systems where people get discounts for
Mm-hmm.
medical services, um, either between 50 to 100% medical discount of medical bills. We've also asked hospitals to automatically apply discounts on patient bills, on patients' incomes. Let me read that.
Mm-hmm.
Automatically apply discounts on patient bills based on the patient's income or
Mm-hmm.
participation in other government programs, requiring that people not have to apply for financial assistance programs, but they can automatically get these discounts on their bills. We've also asked hospitals to not sell medical debt for
Mhm.
consumers who have incomes at 300% or below the federal poverty level.
That's a
So
big
not
thing
sell
right
those
there.
medical debts to debt collectors. We've asked hospitals to cap interest on medical debt to 3%, and then ask them to commit to not report again medical debt to certain agencies. So that's a barrier I think that we are doing a great job in addressing. Um,
Yeah, I think that that's really important. Is there anything in on the forecast moving forward in terms of that middle income, family that is above the 350% federal poverty line? Oftentimes we have these conversations. We're doing wonderful things to help those who are in lower socioeconomic space, but it's that middle gap that I make too much for this, but I'm still struggling. Families are still struggling. So do you know of anything as far as North Carolina is doing to help those families that are working class families, some that still may be working for us at HSS, or just in those everyday positions, where they may be eligible to actually participate in some of these programs?
yeah, I would say the medical debt does address some of that need.
Hmm.
I remind you that Medicaid expansion is targeted for people who are at 138% of the federal poverty level. This
Okay.
medical debt almost triples that, looking
3%.
at people
Okay.
whose income is at 350%. And so
Okay.
compare, obviously it doesn't address all the needs, to your point.
Absolutely.
There are
Hmm.
still some people who are struggling. Um, but it's another option available. So if Medicaid expansion targets one group up to 138% of the poverty level, then
Hmm.
having this medical debt relief program that focuses at people at 350% does expand the group of people who could benefit from some support and services.
Very good. I thank you for sharing that.
Yeah.
What Go ahead and Ms. Farrington.
No, go ahead. You're good.
um when looking ahead, what is your vision for where North Carolina is heading in health equity? And how do you see the Office of Health Equity's role evolving to meet emerging challenges ahead?
So, my vision is that of the portfolios, which is that we will foster, as you've mentioned before, fair and just opportunities for all people in North Carolina to achieve their healthiest outcome. That's why we exist and
Hmm.
come to work every day. Um,
Yes.
and I think with that vision, it includes addressing a broad group of populations. We've talked about people in certain racial and ethnic groups, people who live in rural communities, those who are involved in our justice system, and people with disabilities, because we know people with disabilities have shorter lifespans. People in
Hmm.
rural areas live shorter lives, and those are the ones who need greater access to care. I think how we have to another issue, though, I think that we have to address. You talked about barriers is I believe addressing health disparities is everyone's job,
I do too.
right? It is the
Hmm.
vision of our department to do that, but it's bigger than us. It's everybody in the community because I think that one of the barriers to our doing this work is sometimes people think that health equity is about a specific racial or ethnic group. And I
Yes.
hope that we've made the case today
Hmm.
that it's not about race, only about race and ethnicity. Now, structural
Hmm.
racism does contribute to poor health outcomes for certain racial and ethnic groups, but it's about that and more
That's
because
right.
we know that there are lots of people who are experiencing health disparities, and I think the barrier, the misperception that it's about a specific group is something that I think that we want to change. And one of the ways that I think we can achieve this vision that all North Carolinians have their healthiest outcome is by building allies and increasing people's understanding is that it's about all of us.
That's
Um,
right.
and that when some of us experience poor health outcomes, there are costs that are accrued to all of us.
To all of us, that's
Um,
right. Mhm.
and it's not just a moral argument, but there's a physical, a
Mhm.
financial argument to be made
Economic,
now,
yes. Mhm.
because um, when there are certain populations in our community that experience poor health outcomes, the cost is attributed to all of us because it
Absolutely.
is the tax dollars of North Carolinians that help support our public system,
Mhm.
and creates a system that's available to everyone,
Mhm.
right? Our public infrastructure system is available to everyone. Hopefully, you can, as a person, you can afford to care for your own needs, but our system
Mhm.
is available to everyone in crisis, as an
Mhm.
example, and to anyone who needs to access it. So there's certain costs that are going to accrue to us when certain of us don't have full access to care. And so I think that building allies is one of the ways that we can achieve this vision. I think increasing knowledge of everyone, so that people understand what are the disparities that we're seeing, how can we address those disparities, and what role can they play in addressing those disparities is one of the things that we want to accomplish um, in the next years to come.
I would definitely agree with you, and that's something I actually really champion when I talk about health equity. Try to help people understand not only is health equity in terms of, as you stated, it does focus on race, but it's race ain't it? It's people with disabilities, it's veterans, it's elderly, it's everybody. And also try to get people to understand that health equity is not singular to medical spaces. It is every space. If you have a industrial space, and let's say someone shows up and they're working the midnight shift, for example, and let's say they end up falling asleep on the job because the hours that they're working is too extensive and too much for them, that ends up causing another issue. Now that person is out if they end up getting injured because of their sleepiness, right? Or falling asleep at work and hurting themselves at work, then it's a ripple effect, that people don't understand. It's not isolated to medical. It's medical, but it's also all industries, all professions. It is ensuring that every person that is employed by you has an opportunity to be able to live their best health, and how that plays a part, and whether it's employment. Some people may not be employed, so we've got systems in place to assist those who are not employed. But people really need to grasp and understand that health equity is all community in all spaces. It's almost like one health, like you said, a holistic approach in every single thing. So I thank you for broadening on that. Is there anything that you want to share in our last couple minutes that we have? I think we've got about 10 minutes. And if anybody has a question, some joined and some people are actually viewing from other spaces, so they're not actually in the webinar right now. But if you have a question, I will welcome you to put it inside the question and answer box, and we will answer that question for you. But is there anything that you want us to know moving forward, and just how to live our best life in terms of health equity?
I appreciate that question, particularly because advancing health by increasing opportunity and improving outcomes for people who face greater health and situational challenges is our priority. And our
Mhm.
Secretary Cody Kinsley often says that a system that fails some of us fails all of
Fails
us.
all of us.
And North Carolina is becoming a more racially and culturally diverse community, and we have to
Yes, it
continue to
is.
prioritize all populations.
Mhm.
And I believe that there's um, more that binds us together than separates us. And so I do believe that we have a great opportunity to continue to partner together and work hand in hand to address the inequities that we see in our system. One of the ways we could do that, obviously, is by addressing those social drivers of health,
Mhm.
which we know contribute to as much as 80% of health outcomes. Those
Yes,
things are not those medical drivers, right? The
that's
medical
right.
drivers, physical drivers only
Mhm.
account for about 20% of health
That's
outcomes.
right. That's right.
But the other things that impact a person's health their ability to have access to healthy food, to breathe
That's right.
clean air,
Mhm.
to have
Housing.
transportation,
Mhm.
housing. Absolutely. Those things really play a significant role in impacting health outcomes. And I
Mhm.
believe we have to look at our policies,
Mhm.
our programs, how we distribute our resources,
Mhm.
so that people who are living in poor social economic conditions can have an opportunity to live their best life and to
Mhm. Mhm.
experience their best health. The other thing I'll say about those communities is North Carolina, as we become more diverse, are experiencing more people who are migrants in our
Mhm.
community. About 8.3% of North Carolina's migrant community, for example, is from Africa. We have lots of our populations are from um, Latinx communities and from those areas. And so there's much that we could do, I think, to make sure that people have language access,
Yes.
that we can make sure that individuals get services in ways that they can understand and
Mhm.
benefit from. And so those are
Yeah.
some of the things that I ask your audience to partner with us to continue
Mhm.
to make sure that we build a system that serves all of our community.
I love that you said that, especially about language access. One of the things I want to encourage communities, those who may be listening, not just from New Hanover County, but from all counties, is, pay attention to those that are in your community. And especially when you meet someone where English may not be their first language, have that conversation with them if you can. And just explore. You'll learn that there are larger communities. If it's them, then it's more. They're not there solo. There are more people there. I had to learn that in our Charlotte, North Carolina area, just in the mountains or the regional areas of Charlotte, that there's a very large Hmong community. I had no idea that North Carolina had such a very large Hmong community in that space. And they have like a huge monk festival every single year, and just all the things that come with that. So I say, to the point, just echoing and uplifting that you said, we have a very diverse community, growing diverse community. We have a very rich history, very at large educational community that is here, research community that is here. So to what you're saying, we need to be able to partner and align with each other in all those spaces, because we have the capacity to actually eliminate health inequities here in North Carolina, because we're such rich resources that are here, that can actually help those that are from different backgrounds, and also those that are here, native, and from our community. So I want to thank you for taking the time. Oh, we have a question. Let's see, question and answer.
I just saw
Where
that.
can we find more information? Where can we find more information on the medical debt updates that you spoke of?
That's a great question. I just pulled up a
Hmm.
link that I will share.
Okay.
Um, Hopefully I can drop the link. You can go to www.ncdhhs.gov/medical debt. And will I
Okay.
have the ability, on to drop that? I think I can.
I
Can I
got
drop?
it. I just
You
wrote
got
it.
it?
Uh-huh.
Okay.
You said going to www. I just put the www ncdhss.gov/medical debt. Am I correct?
Absolutely.
Mm-hmm.
Yes. That's where you go. We'll have a toolkit for other states. We have frequently asked questions. That site tells us who is eligible, how long people have to wait, when the program will go into effect. Lots and lots of questions for folks to be able to go out and get information. So I appreciate that question.
Yeah, that's a great question. So I dropped the link inside of the chat for those that are looking for that. And if you have any additional questions, you can also reach out to your New Hanover County Social Services or Health and Human Services. You can reach out to me. And whatever questions that you have, I can make sure I can get those answered for you. I can reach out to Miss Farrington. She'll give me the additional resources if there are things that I'm not able to find for you. Miss Farrington, I want to thank you so much for taking the time to talk with me, to talk about a year in review, where we've gone, where we've been, where we are, where we're going. That's kind of like, it sounds like my prayers as a woman of faith. I always say, Lord, thank you for where you brought me from. Thank you for where I am, and thank you for where you plan on taking me. Um, and so I just thank you for taking this opportunity to have this conversation with us. I hope you have a wonderful new year. I look forward to all the wonderful things that we will be doing in North Carolina. Of course, New Hanover County will be happy to partner with you and to uplift any of the things that our state is actually doing, to make sure that our North Carolinians have the best opportunity for health by their own standards. And that's what's really important, is allowing
Amen.
people the equitable approach. I try to teach people that equality is population centered and equity is people centered. And so that means that every single one of us should have the opportunity to live our best life by whatever we state and whatever standard that we set for ourselves. And I love the fact that we as North Carolinians are doing our best to uplift that. So thank you for your time. And
Absolutely.
again, I hope you have a wonderful holiday season. And we got one more question. Look at there.
Oh,
They
question.
sliding in. Oh, she said
Always a
thank
thank
you.
you.
Okay, she just said thank you. But yeah, so have a wonderful holiday. I will give you back 4 minutes of your time. Um, and so you don't have to reclaim it. And I hope you have a wonderful holiday season.
Thank you, Fawn. It's been a pleasure talking to you. And thank you,
Yeah,
everybody, for joining.
thank you. Thank you. Y'all have a wonderful afternoon and happy holidays to everyone.
Mhm.